Okay, so we've made the diagnosis of a biomechanical dysfunction from the diagnostic exam, and that's up in the left blue box there. Coming to the right, you'll see that there's plus or minus screening tests. Now, these are whether or not you want to use them. They are extremely useful when you're screening for etiologies. So if I'm thinking that the patient has a long leg, for example, I'm looking for why they've got a problem with the medial collateral ligament, then I've got screening tests I can do for the hip, for the foot and ankle and so on. They're very useful for that. Now, in the lumbar and thoracic spine, the other one that is useful here is actually position testing, where I palpate the transverse process, look for a rotated vertebra, and then that's where I'll focus my biomechanical exam there. Now, you end up doing the whole thing anyway, but this helps zone your attention onto one area or two areas, or however it is. You don't actually need to do them. They're convenient, but they're not necessary. So if we come to the center box, we've got PPMs and PPIVMs. Now, PPM is for the peripheral joints, passive physiological movements, and PPIVMs are passive physiological intervertebral movements for the spine. Now, if the PPIVMs, and I'm going to concentrate on spinal problems now rather than articular ones, but the same is true for any of this. If the PPIVM is negative, there's a couple of options. One is there isn't a biomechanical dysfunction present at all, in which case your diagnosis over on the left-hand rectangle is wrong. That's one of you. You made a mistake with your diagnosis. The other one is that this could be a hypermobility, and they can be very, very difficult to feel. It's either the test isn't sensitive enough for some of these, or you're simply not sensitive enough to pick these up. One thing you can do is assume that it is hypermobile and come down and stability test the joint to see if there's an instability present. Or if there is, it's a very strong suggestion that this was hypermobile and it was simply missed with the PPIVM. If your stability tests are negative and your PPIVMs are negative and you don't know whether it is or not, get a second opinion. And this can be somebody more experienced than you, or it can be somebody who practices completely different from you. I found when I was in BC, I had some real giants of manual therapy around me. And if I ran into diagnostic problems with a patient, or treatment problems come with that, I would send the patient off to one of these people, get a referral to get an opinion from, and it'd come back and it was very similar to what mine was, both in the form of treatment and assessments. So I found that I did better when I sent to somebody who worked different from me. So that's entirely up to you though. If we can pick up a positive PPIVM, whether it's hypermobile or hypomobile, we come straight down and you can go left or right here. So if we go over to the hypomobile oval there, the rounded rectangle, if you will, we know it's hypomobile. So now we do the joint glides. It's a PAM, passive articular movements for the periphery, and it's a PAVM, passive arthrokinematic intervertebral movement for the spine, or sometimes less accurately called a passive accessory intervertebral movement. So we do that. Now, if these are positive, we know we have a joint problem. Fairly well known. I'll tell you the exception to that in a minute, although I've already mentioned it. A positive PAVM says strongly you have a joint problem here. Now, this is either going to be a pericapsular problem, which includes arthritis, or it's going to be a pathomechanical problem, which is basically what I'm going to call a subluxation. And understand that subluxation isn't the orthopedic meaning of the term. This is a joint that's jammed at one end of its range. So if this is a pericapsular restriction, you'll get a hard capsular endfield. If it's arthritis, you're probably going to get spasm. You're certainly going to get a lot of pain, and you'll probably get spasm as well. If this is a pathomechanical hypomobility, then you will find that you get a jammed end fill with it. Now, if you remember when I was talking about irritable extra articular restrictions previously, I said that the increased tone in the muscle can set up an abnormal axis of rotation, and that can make it feel like it's jammed. Now you've got one test we can do for that, and I'll come to it right now when we shift over to the extra articular hypomobility. It's either hypertonic or it isn't. If it's not hypertonic, it's structural. That is, we have adhesions, scarring, and so on in it. Now, what we can do to separate these two things out is sometimes the end-fill helps. We get a hard capture end-fill if there's enough adhesions or scarring in the muscle. But the easiest thing to do here is to wobble the joint. So we input proprioceptive information, and basically this will defacilitate the segment, and the muscle tone will bleed out of it. So when you do that, and then you end up with improved or normal range of motion after doing that, it's a reasonable assumption this is hypertonic. And what you need to do is find the cause of the hypertonicity, not deal with the hypertonicity locally. If on the other hand this is adhesions, then you're in trouble. You cannot mobilize adhesions like this. This takes prolonged stretching. So if you're going to do mobilizations, it's going to be at least 20 minutes, and it's going to be a stretch on a stretch. If you come on and off it in equal amounts, then that 20 minutes now goes out to 40 minutes. This is what they invented serial and dynamic splints for, was prolonged stretching, because this is what works with adhesions. Coming back to the subluxation, if you're not sure that this is a jammed end-fill, then again wobble the joint. If that jammed end-fill now disappears, it was a hypertonic muscle. Okay. Now going over on the other side, we've done our P-pivum, we've found it's hypermobile, and now we can come down and give some thought to stability testing. Now, stability testing in the periphery isn't too terrible. We've got large ranges of motion there. And often you can see the increase in range, let alone feel it. The spine is a different animal. These movements are so small anyway, it's tough to always know what you're feeling. Now, there's been a couple of pilots done that show that there isn't an awful lot of reliability when these tests are done. My experience has been that people who have learned this in a clinic do better than people who have learned it in a class. And the reason is obvious. I mean, the person who's teaching it can call them over and say, look, come and feel this. That's unstable. And if you do that enough times, they'll start picking it up. But in a class, you can't do that. The other problem with this is that the model we're using here is that the subluxation, the pathomechanical hypomobility, results from an unstable joint. That's its matrix. Pain-free matrix is instability. So they come in not when it's unstable, typically they'll come in when it's jammed up. So if you try and do stability testing on this now, it's always going to be negative. Once you manipulate the joint, go back and stability test it, and you might just be able to pick up their instability. The problem you're getting though is because everybody's sublux when they come to see you, you never get to feel an instability because it's not unstable at the time you test it. So I've almost given up teaching spinal stability testing in the class, and it probably does need to be done in a clinic. So let's assume you're doing this. If the stability tests are negative, it's hypermobile but stable. If the stability tests are positive, it's hypermobile and unstable. Okay, and we talked about the different types of instability, ligamentous and articular, and the diagnostic criteria that goes with each. Okay, so now we're looking at treatment. Now this is simply a continuation of the last slide, as you can see. Across the top there you have pericapsular hypomobility, pathomechanical hypomobility, hypertonicity, adhesions or scars in the muscle, ligamentous and articular instability. So it just continues down from the previous slide. So the treatment for pericapsular hypomobilities, it needs to be mobilized, but they have to be on prolonged stretch. As I say, you can't do this with 5 minutes of mobilization. What mobilization will do to trick you into thinking that you're actually getting somewhere is, of course, deal with the pain. It will reduce the pain, it will reduce muscle tone as well, and it will increase range of motion, but only as much as the muscle will give you. So it's a very good method actually of decreasing tone so that you can stretch effectively afterwards, and it should be done always. Otherwise, most of your stretch is going into trying to extend the muscle out, and it's a very inefficient way of getting a muscle to reduce its tone. So get the tone out of it by increasing the mechanoreceptor input into it, but then your actual mobilization of structure has to be by prolonged stretch. Now, if you do oscillations on a stretch, that is, you do a 4+ and move it to a 4++, for example, so it's being stretched all the time, but just a bit more stretch at times. Those oscillations will stop it getting sore as you're doing the stretch, which will also reduce the muscle tone that's occurring and make things more effective. But as I say, I mean, the patient needs to be able to stretch this themselves, which is difficult in the spine without overstretching other joints. But it needs to be stretched for some prolonged periods. As I said earlier, this was why dynamic splints were built and serial splints were built, because this needs hours of stretching generally. And even talking about mobilizing for 20 minutes or a 20-minute prolonged stretch may not be doing enough. It may not be having a big enough effect on it. You can manipulate pericapsular hypomobilities. It's usually done under anaesthetic. You've probably seen them done with shoulders, and they are fairly traumatic. But in smaller joints, smaller amounts of adhesions, particularly if you give them good stretches beforehand over a period of a few treatment sessions, then sometimes you can manipulate it and get the adhesion to go when you do. It's a different manipulation. It's a high velocity thrust, but it's generally speaking in the position that it's going to stretch that adhesion, whether it's a ligament or in the capsule or whatever it is. So the position of the joint at the time of the manipulation is important. It is certainly not in its relaxed position. For pathomechanical hypomobility, you can manipulate it or you can mobilize it. If you're going to mobilize it, which is a less efficient way of doing it, it will take you more treatments to get the same effect. And that's been demonstrated by Dutch researchers, which I think was led by Koes, K-O-E-S-S. If you're going to mobilize it though, don't do rhythmical stretches. There is nothing for you to stretch. These are erratic grade 3 pluses or jerky modes, but you want to shake this thing up and try and pop it. Now, sometimes when you mobilize what you believe was a pericapsular restriction, you'll get a click when it happens and you'll see that the range has increased. You just made a misdiagnosis on what the problem was with that joint. It was never pericapsular. When you tear adhesions, it takes a fair amount of effort and it's usually quite uncomfortable when it happens. So mobilize it, or better yet, manipulate it. It's more effective, more efficient, and it's probably more effective as well. I would strongly suggest that whichever one of those two you do, you then mobilize it with grade 3 or grade 4 mobilizations, where you're not overly stretching this thing, but what you try to do is increase proprioception into the joint, and that will help dynamic stability of the joint, and it will sort of complement any stabilization therapy or movement therapy that you're going to do later on. But it should do anyway, maintain the protection of the joint for longer than if you don't do it. Hypertonicity, as I said, you need to deal with the cause of the facilitation. It's going to be nociceptive in nature, the cause, and you may have to use screening tests to find it, for example, but deal with its cause. And that could be anywhere within that segment of the tight muscle. For adhesions and scarring, again, you've got to do prolonged stretches. For ligamentous problems, whether it's ligamentous or whether it's an articular instability, it's movement rehabilitation. It's as simple as that. Sometimes with ligamentous problems, you can friction the ligament to get more, to change the way it's healing. So you can break down early adhesions when they're starting to form. You can stop them from forming and then allow it to reform more optimally. But whatever it is, you have to end up doing movement rehabilitation at the end of it. Alrighty, back to the quiz. First we'll talk about the lady, and I'll read directly from the article. The patient with Bell's palsy from case 51A. At breast, the patient has slight widening of the right palpable fissure, and when attempting to smile, the patient experiences clear weakness of the right side of her face with pulling of her mouth to the left. When closing her eyes, the right lids cannot be completely approximated. When asked to look surprised, the right frontalis does not contract. So you get a wider gap between the eyelids with a Bell's palsy simply because the lower eyelid cannot be raised up to meet the upper. If you look at the pictures of her at rest, she actually looks as if she might be ptosis on the left side, but clearly that's not the case when she actually does move her eyes. When we look at the man, the gentleman, the picture you saw of him was him looking surprised, and there's no asymmetry there that you could put down to a palsy. Nobody's perfectly symmetrical, but he comes pretty close. His frontalis is contracting, his eyebrows are raising up, his eyelids are going up as well. But when he tries to smile, you can see that the left side of his face is not doing what it's supposed to do. So the left side of his lower face is paretic, but the forehead muscles are not, and this indicates a supranuclear or upper motor neuron lesion from a stroke. In both cases, determining asymmetry is not easy unless the muscles are asked to work. In the cranial nerve exam for cranial nerve 7, the patient is asked to smile and frown, and if both are affected, the odds are that this is a peripheral palsy. If only the smile is affected, then the upper motor lesion must be assumed. You can't have the other way. You cannot have the forehead muscles paretic and the lower facial muscles working simply because of the way this nerve partially decussates. So I hope that was helpful. And it just needs more observation than we're used to doing on a face. Okay, I hope you enjoyed this quite basic review of the process involved in diagnosing and treating biomechanical dysfunctions. It's easy to get overcomplicated with this simply because of concentrating on details and missing the larger picture. So mostly I've concentrated on the processes here, so I hope you get something from it. I have been asked what these last frame pictures are. This one is of the promenade in the town of Chapala, Jalisco in Mexico that runs alongside Lake Chapala, the largest Mexican lake, and I think it's the third largest in Latin America. Anyway, I'll talk to you again soon. You have a good week, month, until I talk to you again. Bye-bye.